I see missed most often is an alcoholic comes in, seems to have a good phosphate, and it's not checked on day 2 or day 3. And so when you're going through that refeeding and you have the appropriate history, it's probably worthwhile to go ahead and check the phosphate on day 2 and day 3 just to be safe. Another way to think about it is anytime you're worried about thiamine deficiency, worry about the development of phosphate deficiency. Okay, so once it gets under 1, there are 5 body systems that can go haywire because of the lack of ATP. And I hope this will all make sense. And you can die from hypophosphatemia. And I actually, excuse me, didn't, and that's from the nuts I just ate, not from my COVID that I don't have. We actually saw a patient in Huntsville die of hypophosphatemia. He came in with a phosphate of 0.8. It was ordered stat. It was not measured. And by the time were ready to give him phosphate and got called, he was in VFib. So, but let's start with the brain. So we're gonna, for those of you who can see me, I'm gonna use my hands to show you. We think about the brain first. 2 problems with hypophosphatemia: altered mental status, and it can actually be stupor or coma because you need ATP for neurons to do the neuron thing, and seizures for the same reason. And the seizures can be very bad seizures, very concerning seizures. So worry about those 2 things with hypophosphatemia. That's the brain, okay? For those of you who can see me, the heart. 2 problems with the heart. You need phosphate to make muscles work. And since the heart is a muscle, you can get severe heart failure because of lack of phosphate, and the heart just is not going to contract appropriately. The second thing is arrhythmias, and you can get any kind of arrhythmia, including VFib. And the unfortunate patient about 15 years ago up in Huntsville went into VFib from his hypophosphatemia. So you could die from the seizures. You could die from VFib. In order to breathe, so now we're on the lungs. In order to breathe, you need muscles to work. And if you don't have muscles working, then you can get respiratory failure. Then the 4th thing is the muscles themselves can actually have rhabdomyolysis. You can get acute renal failure from muscles breaking down because of the lack of phosphate. So all of those make sense because we're real familiar with ATP and how that interacts with the electrical system and how that acts with muscles. The last is the hematological system. And it turns out that you need phosphate and ATP to make the red cell membranes work appropriately so you can get hemolysis. And you also need it for white cells to function properly. So people who are hypophosphatemic are more likely to get infections because their white cells aren't working well. And any of those systems can end up in death. So those are the big 5 systems that I want you to remember. So questions about that, or just say that you're following me? I need some kind of feedback from the audience here. Everybody's asleep. Feedback from Sean Carter. Thank you, Sean.
There's also, for anyone that wants to have a little fun, there is a reactions button. So you can give a thumbs up, you can clap. I'm looking for the thumbs down, but I don't see it in case anybody needs that. But there's other ways you can participate.
So I got feedback, more feedback. What kind of timeline? So great question from Courtney. What kind of timeline would you expect for heart failure? So you're going to have decreased cardiac function, possibly when the phosphate gets below 1, and that is almost immediate because the muscles weaken once they don't have enough ATP. So it's not. There is a theory that I've read that intracellular phosphate may be the reason that alcoholic cardiomyopathy, when you stop drinking, recovers so completely. Whether that's true or not, I don't know, but it's a nice story that I like to tell. So so the heart failure, it's because it's myocardial dysfunction, it's can be quite rapid, and so you'd want to worry about that. Okay, and Kramer summarized everything very nicely here. Thank you. Great.
One other question, Dr. Center. How much of this will you see when the FOS is above 1? So if a patient has a FOS of 1.8 or 1.5, will you begin to see any of these symptoms or signs?
So I've traditionally, that is the perfect question, Ryan. I've traditionally read that you get in real danger below 1. The article that I will send you, which is a nutrition review article from about 15 years ago that I found that I thought did a very nice job, suggests that you start to get some problems below 1.5. And you could easily imagine that the muscles are not going to work as well once you get below 1.5. In 2020, once the phosphate is below 2, I'm pretty serious about repletion. And once it gets below 1.5, I get extra serious about repletion. I don't remember the exact numbers because, as everyone knows, I don't write orders and charts. I'm not allowed to. Up to date, you can look it up, and please look it up. The article I'm going to send you also has information on how to replete phosphate. If you can take it orally, that's great, but it's relatively easy to give IV also. If it gets below 1.5, I would actually try to do both. It's a very good reason to never start glucose on someone who might be having a refeeding syndrome in their IV without checking a phosphate and checking a phosphate the next day. So any alcoholic who comes in deserves to have their phosphate checked. Now, the same people as as Jamie mentioned earlier, will also have hypokalemia and hypomagnesemia. We're really getting at all the intracellular electrolytes, but they usually won't be low enough to kill you like hypophosphatemia will. So, do banana bags have dextrose in them? I don't know the answer to that. Do you know it, Ryan? Does a banana bag
Typically, I believe they're done in D5, so it depends on how you mix it. But when we used to write the orders for them handwritten at the coop, we would always put them in D5. But someone can look that up online and see if they find anything else. And I'll look it up as well.
Yeah, so I would. So Google says saline versus dextrose. Thank you very much for that. I would be very worried about someone who got glucose for two reasons, both for the thiamine and the phosphate. So anytime you have an alcoholic, if they've gotten some, I err on the side of giving extra thiamine, and I err on the side of checking the phosphate, and once it gets below 2, starting to treat it. Have people heard this before? Is this new information? And I like what Ryan just wrote in the chat. I tend to use normal saline or lactated ringers, whichever is appropriate for the patient, rather than giving IV glucose until I have a better understanding of the patient because of both thiamine and phosphate. I think that almost wraps up the phosphate. Are there any other questions about phosphate?
Wait, what?
Okay. We got some people talking. Is that the Bean team? Who's talking? Okay. Well, I hope that was worthwhile. And if anybody runs into hypophosphatemia, please text me or email me or something. And great. It's time for us to go to the next topic because I was told 25 minutes per topic, and that was about 20 minutes. And it's better to be shorter than longer anytime you're doing a conference. Is everybody ready for diuretic resistance? So, same question to everyone. How many people have seen diuretic resistance? Let me know in the chat. Yeah, so this is a common problem. So let's set up the problem. This is what I see at the VA probably at least once a month, if not more. Patients being treated for HFrEF with recurrent pulmonary edema. They're on a loop diuretic and they come in, they have both right and left-sided failure. They're up 15 pounds. You ask them whether or not they're still taking their diuretic. Yeah, doc, but I'm not making as much urine. I think everybody's seen that. So let's break this down into why it happens and what you can do about it. So this will be several different steps. The trickiest one is if they're on furosemide. So let's say we have someone on 40 furosemide twice a day. And they say they were doing just fine, and then slowly it wasn't working. There are two possibilities. One, they're not absorbing the furosemide, or two, the nephron is adjusting and preventing the furosemide from working by reabsorbing sodium downstream. So let's go through those and talk about how we deal with those two major problems. This is assuming that they don't have a salt lick in their backyard and they're not taking in so much salt that they're defeating the purpose of the diuretic. So the first thing that you always do if someone says that their oral agent's not working is you give them an IV dose and see whether or not they make adequate urine. If they make adequate urine, then the problem is an absorption problem. What do you do in that situation? Well, let's go over the pharmacokinetics of the three major loop diuretics. I'm leaving ethacrynic acid out because every time I hear about it being used is like once a decade. And that's only someone with severe sulfa allergies who really needs to be diuresed acutely. Furosemide has been our go-to diuretic for over 50 years. It was generic when I was a resident, and that was in the 1970s, and you weren't born. But furosemide is very inconsistently absorbed from patient to patient. The best I can figure out is about 50% of furosemide is absorbed, but the confidence intervals are like 30%. So some people absorb as little as 20% and some as much as 80%. So if something happens that changes the absorption of the furosemide, but you give IV furosemide and it works, you know that it's an absorption problem. What can you do in that situation? It's a very common situation. For many years, the only other generic we could use at the VA was bumetanide or Bumex. So furosemide has a half-life of about 2.5 hours. So it lasts about 4 to 6 hours when you think of the number of half-lives. Bumetanide is a little bit shorter, But and the dosing is about 1 milligram of bumetanide to about 40 of furosemide. It's extremely well absorbed, about 90% absorbed. And when that was the only generic loop diuretic other than furosemide, for years I would switch people who responded to IV furosemide but not to PO furosemide to bumetanide with good success. More recently, torsemide has become generic and available at the VA, and it's a little bit more expensive generically than furosemide, but we're talking about the difference between a couple of pennies and maybe 8 or 9 pennies per dose. For most patients, that's not going to be a big problem. Torsemide has an advantage of a much longer duration of action. It probably works for about 12 hours. It also has the excellent absorption rate that bumetanide has, somewhere in the 90-95% range. You probably have all experienced, or many of you have experienced, and I'm going to see if people will acknowledge this in the chat. The cardiologists really like torsemide. There are some data that suggest it might lead to better outcomes than furosemide in people with heart failure. There is a large ongoing study of that exact question right now. But I'm very quick, if someone responds to IV furosemide, to switch to torsemide in the hospital, give them a dose of torsemide. There's a debate over what the right dose is. Is it 10 milligrams of torsemide to 40 milligrams of furosemide, or 20 milligrams of torsemide to 40 milligrams of furosemide? And I think what I always do when I'm the attending at the VA is the last day they're going to be in the hospital and they've been responding to IV loop diuretic, switch them to PO to make sure that I have a dose of PO diuretic that they respond to. But I'm very quick to switch people to torsemide. Whether you need to give it once a day or twice a day, that's something that I probably personally disagree with the cardiologists at most times. I like giving it once a day if at all possible, rather than twice a day, because we're talking about diuretic resistance, but I've seen a lot of diuretic-induced volume contraction also. So I like to use sort of a sliding scale, have them take it when they need it, but not take it when they don't need it. So that's step number one, if the problem is resolved by IV furosemide. So any comments on that? So Danielle asked me, do I choose torsemide over bumetanide due to its half-life? Absolutely. So that gives you a much longer duration, a much greater volume of diuresis. Plus, it's the one drug, not the best studies, but decent studies suggest better outcomes with torsemide and no such things with bumetanide. That's a good question. Thanks for that one. Any other, does all this step one make sense to everybody? I'm sure you've all experienced this. And Sean Carter is speaking Spanish to me. I love that. And the Bean team, since we're talking about diuretics, they're happy. So let's talk about the IV furosemide doesn't work. So this is the classic diuretic resistance problem, and why I like PRN. Thank you. This is gorgeous. For those people who are on computers and can see, he has a wonderful slide. Ryan's put up a wonderful slide of diuretics and their site of action. But the reason I use sliding scale diuretics is because when you pound the sodium potassium 2-chloride cotransporter day after day after day and deliver more sodium chloride to the distal convoluted tubule and the sodium chloride transporter, then that section of the tubule says, there's too much stuff going on here. We got to ramp it up. And what actually happens is you get some hypertrophy in the distal convoluted tubule, and you have an increased number of sodium chloride transporters produced. It actually stimulates the production of more sodium chloride transporters. You've all seen this. You give an IV dose of furosemide, and then you give some thiazide. If you're in the CCU, what they'll do is they'll give an IV loop diuretic, and then they'll give IV chlorothiazide. If you rounded with me, if the patient can take PO, I give metolazone. Why do I give metolazone? Because I've been doing it for 50 years. 50 years? Not quite, 45 years. Metolazone is a longer acting thiazide type diuretic. It turns out any thiazide diuretic will work. And the idea here is it's just like when you took physics and you learned about serial versus parallel resistors. We need to do serial resistance. We do resistance at the sodium potassium 2-chloride cotransporter with a loop diuretic, and then we also do resistance at the sodium chloride transporter in the distal convoluted tubule, and then you get a massive diuresis. This was known for years. I mean, we did this in the 70s. We didn't know why. I didn't understand why until a wonderful nephrologist named David Ellison, and you can look him up to see a lot of great articles on this exact problem. He had an article in the Annals of Internal Medicine called The Pathophysiology of Diuretic Resistance. And reading that article helped me understand what I was doing and why I was doing it. So what I do if the IV loop diuretic doesn't work, so now I know it's not an absorption problem, and I know it's getting to the kidney, then I add one of the thiazides, whether it be IV chlorothiazide, if you think the patient needs IV and can't take oral metolazone. When I give metolazone, I usually only give one dose, and that one dose seems to fix everything for quite some time. I try to never give that more than every other day if I possibly can. So that's your basic summary of diuretic resistance. There's some patients who will continue to be resistant even when you give both a loop diuretic and a thiazide. I don't have good data here. This is going to be anecdotal. This is anecdotal from Dr. Kathy Tuttle, who did a couple of podcasts with me, one on SGLT2s and one on GLP-1s. On the SGLT2, she mentioned that she had patients with diabetes, chronic kidney disease, and were having a hard time managing their volume just with a loop diuretic and a thiazide. When they added the SGLT2, maybe you could bring that slide back up, Ryan. When they added the SGLT2, then they had a good diuresis. And the idea is that in the proximal convoluted tubule is where the sodium glucose transport occurs. And you can imagine that by blocking that SGLT2, you deliver more sodium chloride to the loop where the sodium potassium 2-chloride cotransporter works. Now, the other thing to remember is if you have someone with heart failure who you're treating with diuretics and you add an SGLT2, sometimes you'll end up with volume contraction. Now, the DAPA study, the dapagliflozin trial in heart failure just came out in JAMA, I think yesterday or today. And I was reading through that. They did not have any more volume contraction in people when they added the SGLT2 DAPA than placebo. And remember, that's the study that showed that dapagliflozin improved outcomes in heart failure patients whether they had diabetes or not. And so that's an important article to read. So whether the SGLT2s really cause a volume contraction, I have anecdotal evidence of at least 2 patients I've seen. Dr. Kathy Tuttle, who's both an endocrinologist and a nephrologist and a world expert at this, she believes it happens, but I can't give you good data. So let's go back to the chat here, and I'd love to hear questions or comments from this part of the diuretic resistance talk. So here's a classic question. This is asked all the time. Do you have to give the IV chlorothiazide? And Ryan, I'm going to use generic names rather than the trade name. That's just to one up you. You don't have to. That's like an urban myth, and I've asked a bunch of nephrologists. They both get absorbed, and they both work just fine. People are going to tell you have to do it. If that makes them happy, go ahead and do it. But there's no physiological reason that you would have to do this. The Beam team is worried.
And just real quick, one of the reasons I bring that up is because I think it makes the nurse's life more complicated, and it makes, when we dose them separately and they're trying to do it 30 minutes after the first one, and it can kind of throw a lot of things off. So I think having people be free of that notion, they can just give them both at the same time, it makes it much simpler.
It's always worked for me. The Bean team had a great question. What about gut edema? As best I understand, gut edema slows down the absorption of the loop diuretics. I've not read about it having problems with thiazide absorption. That would be a reason to use IV chlorothiazide if you thought that was true. But trying to find good data on that, I remember there was some data on furosemide absorption. It was still absorbed, but it was a little bit slower. My man, Nick Baldwin, says that he's also had a patient with volume contraction from SGLT2. That's great. So Kramer says, is the volume contraction amplified by other diuretics? I did not make that clear, and I should have. The patients I've seen were also on a loop diuretic, started an SGLT2, and we had one about a month ago that came in with heart failure. They started him on medication. They put him on a strong dose of a loop diuretic, and they also added an SGLT2, and he came in profoundly volume contracted. So I think that, yeah, I think it's the synergistic effect of the bringing more sodium to the loop. So another great question from Cameron. What's the evidence experience for lowering doses of loop diuretics when patients start on SGLT2s? In Kathy Tuttle's podcast that she did with me, she does recommend that. And I've seen that recommended elsewhere. I think that if you're giving an SGLT2 for heart failure, and you're going to be, and they're already on a loop diuretic, that you need to follow them really closely. It'd be nice to have that for a day or two in the hospital and see how much their urine output increases. Now, the problem with increasing and decreasing doses of loop diuretics is an interesting one. Loop diuretics are a threshold drug. Once you get the threshold, more loop diuretic doesn't give any more diuresis. So I used to see people who were on 40 of furosemide in the morning and 20 at night. Well, they were on 20 at night so they wouldn't have to pee and they wouldn't have to wake up at night. There's no reason to use different doses, and lowering the dose, Cameron, I don't think is going to help you, because you have to get it's almost an all or none type drug, the loop diuretics. So I think you solve all these problems by figuring out what a good weight is for the patient. Some patients can go by weighing themselves. Some patients can go by measuring the amount of edema in their legs. Some patients can know they're getting volume overload because they can't lie down. and let them use the loop diuretic on a more PRN basis. If you read the heart failure guidelines for loop diuretics, and you've heard this from the cardiologists, they're looking for optovolemia. And optovolemia means not too dry, not too wet. And you only can get that if you don't have a single dose of the loop diuretic that they take every day or twice every day, but rather take it on the days they need it and not take it the days they don't need it. They may need less doses of loop diuretic if they're on SGLT2.
Centaur, you've thought a lot more about this than I have, but I'm just looking at Cameron's question and trying to think about the way this works. And would you ever have a situation where, you know, you give somebody's threshold for Lasix is 40 for it to work? 20 doesn't work, 40 seems to work well. And you put them on an SGLT2, and now suddenly they respond at a lower threshold for Lasix. I hadn't thought about that before. I don't know if that's possible or not.
I don't think so. I mean, it certainly could, and I wouldn't mind if someone tried that, but the idea is you have to get enough of the molecule into the tubule to block the sodium potassium 2-chloride cotransporter. And you're either blocking it or you're not, is my understanding. That's my understanding. Now, I could be wrong about this. I wouldn't mind someone trying what Cameron suggests. I hope I've answered Catherine's question. How do I monitor a change Lasix dosing? First of all, I use furosemide, not Lasix. Trying to get everybody to use generic names because that's what's on the test. So I'm being a boomer. Excuse the booming. You can make boomer jokes about me. My grandsons make boomer jokes about me. What the way I monitor change it. Thanks, Kramer. The way I monitor or change it is just not have them take it every day, and just take it on the days that their volume is up, whatever way we can measure their volume being up. And I've had patients who would weigh themselves every day and do it based upon optovolemic weight. I've had people do it because they have right-sided failure and they can tell their ankles are swelling. And I've had people who've done it because they can feel it in their breathing when they lie down. I've had patients who had orthopnea before they had paroxysmal nocturnal dyspnea, and as soon as they get orthopnea, or there's some patients who their exercise tolerance decreases when they get a little bit too much fluid in their lungs. So if they can normally walk 2 blocks and then they get down to 1 block, they need to take a loop diuretic. I think having that conversation with the patient and giving them control over the furosemide or torsemide is the way to do that. But I think you do have to be aware, especially in these patients, that we're gonna start giving a lot more SGLT2s to patients who have heart failure, even if they don't have diabetes, because of the DAPA study that we now have the actual study to look at in JAMA. And that should be a Journal Club article at some point in time.
Do you remember it well enough to just briefly give us 2 paragraphs on the DAPA study, or the main headline of what it showed?
The main headline is that outcomes were better with less hospitalizations and less complications in patients with HFrEF, whether they had diabetes or not, who were placed on SGLT2. Now you can get into the weeds, but it was a fairly significant improvement in the relative risk of complications. No difference in volume contraction between being on SGLT2 and not being on SGLT2. I don't know how they handled the diuretics. So it's just something to worry about. They didn't have any diabetic ketoacidosis they didn't have any diabetic ketoacidosis in the non-diabetics. I don't remember if I don't think it affected mortality, Jamie. Jamie asked this, the appropriate question, did it affect mortality? I don't remember that it was powered to look for mortality, but I haven't read it that carefully yet. It's a great question, Jamie, and I'll have to go back and look at that.
And Danielle wanted us to just remind everyone about the glucose effect in the urine and kind of osmotic diuresis from glucose.
So actually, the reasons that the SGLT2 inhibitor enhances diuresis can be a combination in an osmotic diuresis, but that only occurs in the people who are diabetic and have a higher glucose. But remember, it's the sodium glucose transporter, so you reabsorb less, you're blocking reabsorption of sodium in the proximal tubule, so therefore you deliver more sodium to the loop. So therefore, when you block the sodium-potassium 2-chloride cotransporter, even more sodium gets to the distal tubule. Daniel, let me know if that answers your question. She says, thank you. Thank you for asking a question. It is about 10 till, and I've been told that great conferences end 10 minutes early because everybody is anxious to go do other things. I'd like to thank everyone who signed in to listen to me, because it's always fun to have people actually listening to you and caring what you say. And thank everybody who's doing all the hard work in the hospital. I've been relegated, for those of you who understand soccer, I've been relegated to the B team. I'm not allowed to come in for right now because I'm an old guy. I don't know if that's the advantage or disadvantage of being a boomer. But I enjoyed it, and I'll see many of you at Morning Report tomorrow.
Thank you, everyone. Have a great day. Bye.